but I have faith that there's something for you tonight. Thank you.
Are you able to see my slides? Okay.
Sorry, I have shared from my side.
Oh,
Are you
you
able
shared
to
from your
see?
side.
Yeah, from my side. We are on your opening
Yes.
slide. Can you see it? Yeah, we can
Yes, I
proceed.
can see it. Okay. Okay, good evening, everyone, and very sorry for the network issues that we've had. And I hope that we are able to present something that you all can learn something from and get a bit of information from that will help you in your clinical practice and your clinical skills. So we are speaking about regional anesthesia, specifically spinal anesthesia and epidural anesthesia. So in the previous presentation that I did, we spoke about different types of anesthesia, and I thought maybe I should go into a little bit more detail regarding spinal and epidural anesthesia. I'm not going to cover peripheral nerve blocks now. Regional anesthesia is the technique that induces loss of sensation in a part of the body using local anesthetics. Spinal anesthesia, as we know, the space that we inject local anesthetic into is the subarachnoid space, and your epidural space is the one where we would inject your local anesthetic into. Next slide. So why then, what is the advantage of your patient or you choosing to do a regional anesthesia? First is cheap. There's high patient satisfaction. You maintain a patent airway. Because of the vasodilation, there's decreased blood loss, and there's selective muscle relaxation. This is more to do with nerve blocks. And there's also decreased incidence of deep vein thrombosis and pulmonary embolism. So as much as there's they say there's two sides to a coin, there's a good and the bad. What's the other side of the coin that we don't really like about regional anesthesia? A patient will get hypotension. There's a risk of toxicity. Many patients prefer to sleep. Skills are required. Patients can talk. I actually laughed when I saw that patients can talk, because I sometimes don't want to have a very talkative patient. I want my patient to be quiet. And so sometimes I give them Domicum just to keep them quiet. But patients also become very anxious, and it's not reliable for surgery more than 2 hours. But this is more to do with spinal anesthesia. Okay, so we are going to talk about neuraxial blocks. So there's 3 different types of neuraxial blocks that we have. We have epidural block, spinal block, and caudal block. I'm not going to talk about caudal block, but just know that it's there, and we usually do it in little children. Okay, so there are certain things that affect, even if you're going to give your local anesthetic, there's certain factors that affect how it's going to work. So the baricity of the local anesthetic, meaning how heavy it is or how light it is, the concentration of the local anesthetic, the positioning of your patient, the volume that you inject, the level of the injection that you choose to put your local anesthetic into, or even the speed of the injection that you use can affect how well the spread of the local anesthetic is and how well your block is. So I'm going to go, I took quite a lot of time going through epidural anesthesia, because I think most of us do know quite a bit about spinal anesthesia, but I think epidural anesthesia is that kid that everyone is scared to talk to or talk about. So even I have the same kind of discomfort, because in the hospital that I work in, we we don't do that many epidural anesthetic because of the lack of the needles. Most of them that we have expired, so we don't get to perform the skill. But it's good to have the knowledge so that when the the government decides to get us the needles, at least we know what they look like, how we're supposed to use them, and we can give better care management to our patient. So epidural can be given as a sole anesthetic for procedures involving the lower limb, the pelvis, the perineum, the lower abdomen. I also forgot to involve the thoracic. The advantage of epidural over spinal is the ability to maintain continuous anesthesia after the placement of an epidural catheter. It makes it suitable for procedures of long duration. Unlike your spinal, where you give a single injection, you inject your drugs, and you know that it's going to work for a certain amount of time. With an epidural, because you have inserted that catheter, you can always top up, and you can always give that anesthetic and have it continuously being there and working throughout. This means that the technique can also be used also as a for post-op period for pain management, but obviously you use much lower doses of local anesthetic drugs, and you can add other things as well other than your local anesthetics. Okay, so let's look at the differences between epidural and spinal anesthesia. What are the different indications that we use to decide, okay, this patient will be more ideal for me to give them epidural anesthesia or to give them spinal anesthesia? Epidural anesthesia is, I think everyone knows when, I think especially us who are medical people, we know if you're female and you're going to give birth, we always think about epidural. You can give it during labor. If you're having a patient that needs to have a laparotomy, you can consider an epidural. If you're having a thoracotomy, respiratory insufficiency, you know those patients that, you know, they're heavy smokers. You don't want to put them under GA, very old patients. They have some kind of cardiac problem that you really don't want to be. They have previous TB with very bad lungs, with lung fibrosis. Those are the patients you would consider having them on an epidural anesthetic. And you know that the operation will be for a very long period of time. Patients with high BMI and also on long surgery, patients who you know it's going to be a difficult intubation and the surgery is also going to be long. Patients with high-risk pregnancies, Caesars, you can also consider epidurals. Severe maternal vascular, cerebral, or cardiac impairment, spinal disorders where they have scoliosis, you can also consider it as well. Spinal anesthesia, we all know that we use it in the Caesars that we do, short procedures that last less than 2 hours. Respiratory insufficiency patients where the surgery is short, high BMI, but the surgery is short, difficult intubation, and the surgery is short. So you can also consider spinal instead of epidural as well. So what are the absolute and relative contraindications to doing an epidural in a patient? Patient refusal, they say it's an absolute, but I always think it's a relative, because I feel like when patients usually refuse if they are not well informed about what's going to be done on them. And if you take that time and explain to them in their own layman terms at their level, they usually agree, because sometimes we explain in our own medical terminology and we think patients understand. If you get to their level and you explain, they usually agree. Coagulopathy is one of them. Therapeutic anticoagulation. So with the coagulopathy, the Morgan and McHale says less than 100 of platelets, and some of the literature says less than 70 for someone who is who has the skill and will be able to give just a single puncher, will not be giving multiple punches in the same place. Therapeutic anticoagulation would be where your patient is on low molecular weight heparin. If they've had it on the day of when you want to have the epidural inserted, you should at least wait for 12 hours. If patient is on warfarin, you need to bridge them. Bridging means you shift them from the warfarin and you put them on low molecular weight. It takes a bit of time, something that you have to plan. If the patient has a skin infection at the injection site, raised intracranial pressure, or hypovolemia. Your relatives will be uncooperative patient, pre-existing neurological disorder, fixed cardiac output state, any abnormalities of the vertebral column. Okay, so then how do you prepare for your epidural? Obviously, you need to be in an area where you have airway equipment and you have resuscitation equipment for management if anything should go wrong. Monitors should be there. You should be able to assess your blood pressure, your heart rate, and your saturation. You need to obtain a consent prior to performing the epidural. Explain to the patient what you're going to do. Explain the position that you would like them to be in. Explain what they should expect when the epidural starts working and how you're going to test it and how they need to be, you need to explain to them their legs might work, but the pain might not be there. You need to explain to them the complications that are associated with epidural. You also do a pre-anesthetic assessment where you take a history, you do an airway exam, and you do general exam. You need to take laboratory tests as well, coagulation status, you take your hemoglobin, your platelets, your INR. Special attention should be put on patients who have valvulus lesions, cardiac lesions, because those, once you put an epidural, that patient might not be able to increase the cardiac output, and that might be a problem because one of the complications of epidural is that it causes sympathetic blockage. Prior to performing it, obviously your patient must have a large bore IV line because you're going to have some hypotensive episode happening. Shouldn't start an epidural or a spinal without putting an IV line. You would clean the bag and drape in a sterile fashion. You would also take sterile precautions, wearing a gown, masks, and gloves. Okay, so I decided to share this slide. It's from the previous presentation that I did. It's still relevant to this one. So after you have examined your patient, then you would decide and you know which procedure the surgeon wants to perform. Then you would know, okay, now they're doing they're working around the lumbar area or the mid-thoracic area. Then you know that where do I have to inject my epidural, and it even tells you what is the level of spread that you will get if you inject in that level. So if you are planning to go mid-thoracic, and the procedure would be, if they're doing a thoracic or pulmonary or esophageal procedure, you would inject in around T5, T7, and the spread is expected to be around T3 to T9. And then if you are planning to go around, let's say they're doing a gynae or a renal bladder or hip procedure, you'd go around the thoracolumbar area. So your injection level will be around T10, T12, and the spread should be about T8 to L2. I'm not going to go through the others, but you just need to know, and when you take your history, and be aware where you would like your spread to be around. Okay, this is just the same repetition of what I said. If you are doing labor, you would want the level of incision to be about L2, L4, and the block will be about T8, T9, and there will be minimal motor block that usually happens. if it's a hip or a knee surgery, around the same time as in labor, and your block will be around T10. There will be motor and sensory loss, and laparotomy will be around T8, T10, and thoracotomy, like we said, will be about T5, T7. Okay, so let's talk about the anatomy of where the epidural space is, because we need to make a distinction between where the epidural space is going, or where the your spinal needle is going. So you need to understand. So in number one, that's your skin. Number two, that's your ligament. And then number three will be your interspinous ligament again. And then you get your ligamentum flavum. And then just after your ligamentum flavum, you get the epidural space. So when you do an epidural, they always say you go through and you will feel, there will be a moment where you will feel that you're going through the ligaments. You'll also feel that you are almost at the ligamentum flavum. And when you get to that point, you need to now, I was taught that when you're doing a epidural, you're literally going in millimeter by millimeter. And that's how small, that's how little the space is. You don't just go in like we do with the spinal anesthesia, because you'll definitely get CSF coming back, and then you know that you're in the wrong space. Next slide. Okay, so this is another, just to show you where is the epidural space and where is the spinal space, and what you're expecting to find when you've put the needle in the epidural space. So your epidural space is the one that comes after your ligamentum flavum, and then you get that it's a potential space. So it doesn't have any fluid that you're going to have a backflow of. But with your spinal anesthesia, you do get a backflow of CSF. And just while we're on this slide, note the level of your spinal cord, because that's important when you're putting a spinal, and you're doing a spinal anesthesia. You might ask why we do not go at the level of L1, because if you go at the level of L1, you will go into the spinal cord, and you can cause spinal injury. So we go below that because we do not want to cause damage to the spinal cord. So we usually go L3, L4, L4, L5. You can go L2, but I wouldn't go L2. So L3, L4, you can still go, and you go L4, L5, and anything below that should be safe, because the spinal cord is a little bit higher. So there's no chances of you causing spinal injury. Okay, so then how do you then position your patient? You can either position your patient lying in the lateral decubitus position, or you can lie them sitting. And if you make them lie in the lateral decubitus position, we always used to say that you need to put them in the fetal position. It's the same position that you need to put them in. And when you make them lie sitting, if it's a pregnant patient, you also give them a pillow, and they hug the pillow, and you almost tell them that you just need to sit like you're slouching, just to open up the vertebral, so that you can get into the epidurals, into those spaces, and be able to reach the space that you want to go into. Okay. I found this very nice, like something that you can have in theater. Very easy reference for epidural anesthesia. Explains basically what I did explain. your indications, the absolute indications. But what I want to go through is where it says the mechanism of action. If you look at the mechanism of action, there's two arrows there. There's a green arrow and there's a red arrow. The green arrow is coming down. So you need to note that even though either you're giving spinal anesthesia or epidural anesthesia, your nerves will not be blocked at the same time. And the reason is they all have different sizes. And the other reason is that some of them are myelinated, some of them are not myelinated. So just look at where it says small preganglionic sympathetic fibers. Your autonomic nervous system fibers are the smallest ones, so they get blocked way quicker. So your sympathetic blockage happens way quicker. And they are minimally myelinated. And then your cold and temperature will be the ones that will be blocked after. And then your pain, your pinprick will be the next, and your touch and sensation, and then you'll get your motor. So even if you put a spinal and the patient still moves the legs, but they don't have the pain, it's probably working, most likely working. I know the sisters will say, no, she can still lift the legs. No, the spinal is working because the lady came in a lot of pain, but now she's not. And also your blood pressure has dropped. Even if she can move the legs, give it time to work, because it still has to cover those nerves which are bigger than the sympathetic fibers that are there. Okay. All right, so this is a video. It's a quick video just to show you the two different types of spine epidural needles and how you prepare them. This is what you should do when you plan. You can wear gloves before you gown, and you have your sterile area there, and you just open the pack and you prepare them. I don't know if Liseho will be able to play the video for me.
Let me see. Give me a few seconds. No. Fortunately not. Video. Oh, there it is. Oh no. Okay. No. Maybe we can show it at the end. You can send it to me whilst we go through a couple of questions, and then, or even the link, then I will play it at that time. Yeah.
Okay. No, that's fine.
Yeah. Let me try and go back to the slides. Yeah, I was trying, but I don't have, doesn't click. Okay. Okay, so we'll come back to this one. Yeah.
Okay, so you have prepared your epidural pack, everything that you need to have. So I'll just roughly just explain what you need to have. So when you open the epidural pack, you should have, there's a filter and there's a clamp that you clamp your catheter to so that it doesn't move. And you also have your syringe that you use for loss of resistance. You have a needle, and you should have another needle, another syringe that you should be drawing your local anesthetic to localize the area you're going into with it. And there's a way in which you open them. So when you open your, the clip that you open, you connect your catheter, you clip it on, and you put your air filter, and you have to inject a couple, maybe like 10 mils or 5 mils of saline that is clean, just to check that your catheter is patent, and you will be able to inject the drug once it gets into the patient's epidural space. It's difficult for me to explain, but hopefully we'll play the video and you can appreciate what I was trying to explain to you guys. So when you're doing epidural technique, you should be thinking of 4 things. You should be thinking of the 4 P's, which is your preparation. You're going to position the patient, and then you will project and also puncture. So I just want to go through the projection. So there's 2 ways of doing. You can either do it midline or you can either do it paramidline. So most of the time we only think of midline because that's what we used to, because of the spinal anesthesia technique that we do. But when you think about it, when you're looking at the cross-sectional area of the spinal cord or neuraxial axis, the epidural space is not just at the back, it's everywhere. So you should be able to go, paramedian means you're going on the sides of the vertebra, you're not going in the middle. So you can also use that, but I have to say I've never used that, but that's another way of trying to get into the epidural space. So just know that you have those 2 projections that you can use to be able to give your patient an epidural block. Okay, so some of the local anesthetics that we use, we still use your normal bupivacaine. There's also raw bupivacaine, lidocaine. Some of these drugs are chloroprocaine. I've never used that. I've used lidocaine, bupivacaine, and ropivacaine. Those are the concentrations that they advise that you use and roughly the onset of action that you expect and the duration of action that they roughly give you. You notice that bupivacaine gives you quite a lot of time, 120 to 240 minutes. And if you add epinephrine or adrenaline, it gives you even more time, but not really that much because it's still 120 to 240. But you also have maximum doses that you can use on the patients as well. So there is another term. So you might ask a question, if you have given at the beginning, if you've given a dose of bupivacaine, how much should you give when you top up? So they say that you need to give half of the dose that you have given, and you shouldn't wait for the patient to feel pain before you top up. You know roughly how long it will take for that drug to start working and how long it's supposed to work for. Don't wait for the patient to start feeling pain before you top up. Remember, the beauty of epidural is that you can give a continuous medication. But with that said, you also want to also check the level of blockage of your local anesthetic. At least it should be about 2 segments below before you start topping up the patient with another one. That's just a safety thing that you do. I forgot the terms that I think it's called 2 segment sign or something. That's another thing that you can do so that you know when is the right time and you know how much drug you use. So you would use half of what you used at the beginning to top up the patient. Okay, so I had actually deleted the slide, but anyway, I wanted to just talk about to inform you that there's other drugs that you can use on top of your local anesthetics, and they're given for other reasons. Initially, you might be using it for anesthesia, but then you might want to add maybe clonidine for pain. You might want to add ketamine for pain. And the other one that it's not on the slide is using dexamethasone, which you might use for anti-inflammatory purposes. That will be for pain. Some patients have epidurals just for pain management. It's not for that you want to perform a procedure. You can also give the long-acting steroids for patients just to manage. It's usually the neurosurgery patients that have spinal injury, not spinal injury, that have like spinal spondylopathies, yes, arthropathies, and you can give them dexamethasone or give them steroids that will help with the inflammation happening in those, maybe at whatever level that the patient is having pain in, and that relieves them for a couple of months, and then they come back, and then you can give them more doses of that. So it's also for pain management. It's also for to relieve if patients have some kind of arthritis or something like that. Oh, this is another video. So this video was just to show you how an epidural is done in a pregnant woman, and just to show you where the needle goes, and how the patient is positioned, how you thread in the catheter, and how you put the catheter after you have inserted it into the epidural space, and what kind of instructions do you give also to the nursing staff after a patient has an epidural catheter inserted in them, and when do you remove it as well. Okay, so this is quite a lot of information, but I will try to I just felt like this was important for everyone to understand factors that affect your epidural. I did say them at the beginning, but I didn't go into details. So even I didn't know this, but apparently your lumbar injection, if you're giving a lumbar injection, there's usually a delay at the level of L5 and S1 because these nerves are a little bit larger. And so it takes a bit of a while for them to be blocked. And also in the thoracic area, in the upper thoracic and the lower cervical, there's also a resistance to blockage due to larger size of your nerves. So just be aware of that. So you might have to give you might have to remember that it's not because your epidural is not working. It's probably because those nerves are not as easy to block as the other nerves because of the size that they have. And then when it comes to the dosage, a higher volume of the low concentration will block much more of a segment. But obviously that block, because your concentration is much lower, it's not going to be a very dense block. It's going to be a lighter block. So you need to know these things so that you know that if I'm going to give a smaller volume, it's not going to cover a lot of space. But if I give a bigger volume with a low concentration, even though it's a low concentration, it's going to cover a higher, more segments. So if you are giving it a T5, you want it to go T8, T9. But if you're only giving like, I don't know, 25 mils, not 25 mils, sorry, 20 mils or 10 mils, it's probably going to cover less than what you want. So you need to be aware of that. You need to give a higher volume. And because drugs have doses that you're supposed to give, sometimes we do dilute them so that it can cover a much bigger area. But remember, you can still top them up. So don't feel like because it's not covering a larger area, it's going to finish quicker. It is going to finish quicker. But remember, with the epidural, you have an indwelling catheter that you can always top up and continue to block the area, around where you want it to be mostly. So I did speak about topping up, giving repeated doses. and also not waiting for the patient to feel pain before you top up with analgesia, with local anesthetic, sorry. So age, height, weight, they talk about this. Does age affect your epidural? Well, the older the patients become, they say there's a decrease in the size and the compliance in the epidural space. So yes, you need to give them less volume. You can't give them the same volume as a young patient. The taller the patient, that may require dosage, but they say the safest way to approach this is to give those incremental doses and keep monitoring the effect of the drug rather than just giving a large dose and you have this effect that you don't want. So give a dose that you're comfortable with or the dose that is required, and then keep topping up and keep monitoring the effects of the local anesthetic. When it comes to weight, there's no correlation between weight and the volume of local anesthetic. Although when a patient is very morbidly obese, you have to consider that because of the obesity, the epidural space might be compressed. So you might find that the space is a bit smaller. So it does affect the volume that you need to give the patient. When it comes to posture, we know that they always say when you finish giving a spinal, you need to put the patient flat quickly because the spinal will be spread towards the lumbar area. That's still what is assumed as well. It will either go to the lower lumbar and the sacral area and it will block it there, and you won't get a good enough block if you are aiming to go maybe around the umbilical area. And also if you have a patient in the lateral position, the block will most likely go to the side that the patient is lying on. So you just need to remember that when you're giving blocks. In terms of vasoconstrictors, they work. So they say they work more with spinal anesthesia, and they don't really make that much of a difference with epidurals. However, the vasoconstrictors that they put with the local anesthetics, they do reduce absorption of the local anesthetic, and they do reduce the risk of toxicity. So that's how it works, but they don't really prolong the action of the local anesthetic. Okay, so what are the complications? You've put in a spinal, you've secured the catheter nicely, you've given instruction to your patient, to the nurses, and now what are you expecting to happen after you've done that? What are some of the things you should be aware might happen because of these drugs that you're injecting into that space? So in the cardiovascular system, you might have hypotension, there might be some bradycardia, and bradycardia is usually because of either the level of the block that you're giving. If it's quite high, the heart might be involved, and you might be blocking certain areas of the heart, and you might get a bradycardia as well. And the respiratory system, usually this happens a lot with spinal anesthesia, where a patient will say, I can't breathe. And it's usually because the spinal is so high, it's probably blocking some of the intercostal muscles, and the patient has difficulty breathing, especially in pregnant women who are already compromised with the pregnancy. They will just say to you, I'm unable to breathe. So that's what you might expect. When it comes to gastrointestinal, there's a predominant parasympathetic outflow. So peristalsis is active, and it's inactive, and peristalsis, and the small bowel will contract, and they say it enhances surgical access. So your surgeon will be in love with you at this time, like, wow, I can see everything I need to see. when it comes to the endocrine system, the only thing we don't like is that your adrenal glands will be blocked. And if you're having a patient or a patient that you want those catecholamines to be working for you, you might block the release of them because you've blocked those nerves. In genitourinary system, patients tend to experience urinary retention with the epidural blockage. Next slide. Okay. So, spoken about epidural, I hope the only thing that I didn't touch on with the epidural is what of instructions do you give to sisters? So they need to look out for those signs. I didn't mention that those signs, the hypotension, the bradycardia, the difficult breathing. So a patient who has an epidural should be monitored. Blood pressure should ideally be monitored regularly, and you must also tell the sisters that they call you if there's something that they're not happy with, because you're the one who inserted. If there's someone who they can call, you write their name. In the hospital, we used to have a form every time epidural. We would fill in the form with all the instructions of what to do if 1, 2, 3 happens, and which person to contact should anything happen. So it needs to be that you need to know that patients that are on epidurals, they need to be monitored. You cannot give it and then leave them like that. You are giving drugs into that space, and those drugs have the potential of causing hypotension, causing brady, and basically, blocking certain nerves that we don't want to be blocked. Okay, so now we come to spinal anesthesia. So spinal cord extends, we've already spoken about this, extends to the level of L1 in adults, maybe around L2 as well, around there. And in infants, or in children, it ends at L3. And we all know that our CSF, the subarachnoid space, that's where the CSF is, and that's where we potentially want to go into. And that's the picture. I think we've had a lot of pictures. I think by now you guys will be masters of where epidural is and where the subarachnoid space is. Next slide. Okay. So with the spinal anesthesia, obviously the positioning, it's the same as epidural space. You can either have them lying or you can have them sitting. And when you have them sitting, even when they're lying, we know the supraspinous. We look for the anterior superior spine, and that's our landmark, and that usually gets us around L4, L5, and that's where we can actually go into L3, L4 as well, and that's where we want to go into, because we know that our spinal cord ends at L2 or L1, and we know that is where your cauda eguina is, and where your pool is, and where all the cauda eguina nerves are coming from. So you need to know your landmarks, you need to know your anatomy, so that you can appreciate when things don't go right, what has gone wrong. Okay. Next slide. Okay, so this is a nice summary of spinal anesthesia. It's like the one with epidural. It gives you a definition of spinal, it gives you contraindication, and then it also gives you information about the risk that can happen. The one that I'm very interested in is high spinal. I think sometimes we have high spinal, but we don't know that it's high spinal. So there is a partial high spinal and there's a total high spinal. So high spinal can happen where the patient has a blockage. So high spinal happens if you have injected the local anesthetic into the space and the spinal space, and it goes way higher than what you want it to go, basically. The drug goes way higher than you want it to go. It starts blocking nerves that we don't usually want, because we usually want the, your T10, around T10, T6 to be blocked. But anything higher than that, remember that T4 is around your nipple area. It's around where the bifurcation of the trachea happens. So if the blockage is around T1, T4, that's quite high. And that's where your heart is lying as well. So one of the signs you'll have is that patient will start complaining of difficulty breathing. They'll say they're lightheaded, and you might get a bradycardia as well. If it goes to about C6, C8, they might say they have tingling of the hands. That's another sign that they might have. And if their block goes around C3, C5, then you have respiratory compromise. Then the patient might stop breathing, and then or might have a lot of difficulty breathing. If it goes to the brainstem, they might have slurred speech, loss of consciousness, and that's where you act. And we need to know these things so that we can act quickly when they happen, or we can know how to manage them when they happen. And we can even monitor the patient, because sometimes it's not a total block that requires you to intubate the patient. It's maybe one that requires you to give patient supplemental oxygen, one that requires you to watch the patient closely, and one that requires you to alert the surgeon or alert people around you that this might be happening. And it's one that also gives you the opportunity to start preparing for the worst if it's going to happen. So we need to know what are the consequences of the spinal anesthesia as we do them, and we need to know the signs that might happen. If we get into trouble, what do I do next? Hence, when you do anything, you need to be prepared for GA. When you do a spinal, be prepared for a general anesthesia. Okay. And then I've already spoken about most of the things, and I also spoke about the adjunct drugs that we use. It gives you information about the nerves as well. What I explained about the nerves, you can see that it says the most sensitive, it's the B fibers, which are your sympathetic fibers, and your least sensitive are your motor fibers. So now you guys know that when the patient comes in pain and they still have motor, sorry about that, and they still have motor activity, it doesn't necessarily mean your spinal is not working. It's probably most likely working because they don't have any more pain and your blood pressure is dropping. So you just need to give it time for those nerves to be blocked by the local anesthetic. Okay. So then I said that if you have a patient, you can give them a pillow, they hug a pillow, and you can have a chair under their feet so that you can have them in that position where your vertebral open and it's easy for you to put in the spinal. I just want to go through the part about the different just the one with the different needles that we use. So everyone loves the 25 gauge needle, which is quite big. And the prescribed needle is the 22 gauge needle. Actually, it's the other way around. Yes, it's the smaller one, the orange ones that we use. Those are the ones that are prescribed, because the black needles that we use, they cause post-puncture headache. There's more CSF leakage. And I know that everyone is uncomfortable with the needle that has an introducer. But with practice, you get used to it, and your patient doesn't come with the headaches because of the CSF leakage that they've had. Okay. Next slide. Okay, so this is just a repetition from what I've said already, your immediate complications will be hypotension. After the spinal, you get a bit of bradycardia, you get cardiac arrest, you can get high spinal or total spinal block. There's also urinary retention, there's epidural hematoma bleeding. I didn't speak about post-puncture headache. They can also get that as well. So I just wanted to go just briefly on high spinal. They usually have severe hypotension, bradycardia, difficult breathing, and then they lose consciousness if it's really like a total high spinal. So your management will be obviously you having low blood pressure. You might have to give them vasopressors. You might have to give them atropine to sort out your bradycardia. Patients not breathing on their own, so you might have to intubate them and ventilate them. They might even need adrenaline support, and you need to consider also putting the patient in ICU for ventilation. So high spinal is one of those things that we don't like, but it's one of those things that do happen way more often than we actually think. And most of the time when it happens, we are so unprepared for it. But you need to just understand that it doesn't, because I think all of us think that high spinal is going to happen as just like, it's just going to be like block. And you do get some level of high spinal, but it's not total spinal that happens. Like I said, you might get a blockage as T1, T4. Patient might say, I have difficulty breathing. They might not have a total block. So when we don't see high spinal total block, we tend to think that it's not there. But it does happen way more often than we realize. And we need to be ready for it and to soften. Because if you waste time and you don't intubate the patient, then the patient becomes hypoxic. I actually had a case where a patient became hypoxic and patient went to ICU, and the recovery was a patient with a low GCS. So if we act quickly to these things, we can, we can save people's lives and we can have better morbidity of patients than actually changing a life of someone because we didn't pick it up early and we didn't act early. Next slide. This slide was supposed to just show the differences between epidural and spinal anesthesia. The indications of epidural might be for surgery mid to lower body, and then spinal, it's usually lower body. The procedure, obviously with epidural, it's longer because you can always top up the local anesthetic. And then the spinal, the procedure is much short and brief. The onset time with epidural, it's slower effect because most of the time your drug is a bit more diluted and it takes a bit longer to start acting. And your spinal, it's a bit fast and effective. Fast, effective onset. And then with epidural, you need to redose because you have an inserted catheter. But with the spinal, redose the patient. And the possible complications, we already spoke about them. And I think we all know the possible complications of epidural and spinal anesthesia. Okay. Okay, so there's something for everyone. Do you prefer local anesthesia? Some people say I'd rather prefer an imported one. So thank you for listening, and thank you for having patience. I really, really wanted to give this presentation. It's one of those things I thoroughly enjoy teaching, even when I'm at work with the interns. Spinal anesthesia. Epidural was a new one for me, but it was a good way for me to remind myself of some of the things that I had forgotten. Thank you. Any questions?
Yay. There's at least one from me. Do you have you know what I prefer, the imported one. The question is, do you have it? Yeah, that's the question, bro. You know what I prefer, but where is it? Colleagues, yeah, thank you for, I must appreciate you for really, really staying through and through. And yeah, you have made this to be an amazing experience. Yeah, so let me then do justice to your questions because I think it's going to be important. Just give me a few seconds. Let me see if I can change my slide here and do the magic. Yay! There we go. Mpo, I hope you have some time. I heard
I,
someone there in the background saying, "This is my time." What are you
yes.
doing, mommy? They own the time. I know them very well. I was just laughing, saying, "Yeah, no, 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 you must."
Yeah.
Anonymous, you deal with CEOs that are not innovative. Hey, let's leave the leadership stuff. Let's go straight. Okay, let me find because I think I was about leadership as I was buying time. So yeah, let's start with Santos. Will come back to the diploma stuff. Okay, Anonymous, please. Oh, Anonymous says, please do not throw away expired epidural equipment. We can use them for educational purposes in the skills lab and the mannequin. Yeah, what do you think of that? Keep them for clinical care platform for the skills
We'll keep them.
building sessions.
We'll keep them.
Awesome, awesome. Anonymous is saying, is epidural the same as general? Let me allow you to respond to it. I think a straightforward one.
No, it's
Yeah.
it's it's not the same because with the epidural, you're blocking a certain, like I
Mm,
said at the beginning, you're blocking a certain part
mm,
of the body. And if you go to the first slide, I have a nice diagram showing GA, showing regional block.
mm,
If you look at the GA, that person is covered from the face downwards.
mm,
So a GA is
mm,
a complete block of everything. So it's not the same.
mm, mm. Thank you.
But can I
Yes.
just further explain? But the nice thing with an epidural is that you are able to perform some of the surgical procedures that you would normally perform in a GA. You're
Okay.
able to do some of the thoracic things. You're able to do some of the laparotomies. I think that's why they're asking. You can do a
Yeah.
laparotomy depending on which level of block you're blocking. Like I explained, there's different levels of block that you
Mm,
can choose based on the type of surgery that your surgeons want to perform.
mm. I was going to be nasty and say it can be general if you have missed the epidural space and it's in the abdomen or something. Anyway, I was just being nasty. Especially as we try the para, what did you say? The para median.
The
Is
paramedian.
that the right thing? Some people will go really, really para, like far from the court. But anyway, I was just being nasty. Yola says, let me put it up, says, is degenerative spinal disorder a complication of an epidural or spinal? Have you ever had? Yeah, I don't
No, it's
know.
not.
It's not a documented.
It's a no, it's not a documented, but I would think it's a more physiological changes that happen. It's
I think
not.
the question is bigger. Let me see if I can show the full question. Oh, Yola, you had a follow up, one of the of a previous. Yeah, I think I've asked the question correctly. Okay, awesome, awesome. Mpo, those videos, is it a link or is it an actual video? Is it the YouTube link
It's an
or
actual video, but I can send them to you. Let me
yeah,
just
if you can,
access them so that.
whilst we take the questions, I think it will be nice, especially the one where you were showing the preparation and other things. I think it's going to be even if it's via WhatsApp or email, whichever way you can, it's fine. And then hopefully you can multitask because I know
I'm
women
trying to.
are good multitaskers. There's someone there scratching you, say, hey, mommy, you are presenting and you are sharing videos. So Nali says, if possible, would appreciate being able to access the slides for peripheral nerve blocks. Oh, you mean these particular slides? Yeah. They are uploaded on the platform as micro lessons. So now just confirm if you are a member. If you are a non-member, you might struggle a bit, but we will come back to that. Snetemba says, I have seen patients get asked to lift their legs when they complain that they are feeling pain after spinal anesthesia has been given. Is this a good or a bad practice, Mpho? Do you ask patients? I foresee
No,
problems with
it's
that. Yeah.
if you, I mean, if you understand what I just explained, that your motor nerves are bigger and they take longer to get blocked, it's not a good indicator that your spinal is working or not. So your good indicator is your drop in blood pressure. Eventually, your motor nerves will be blocked, but it can't be the first thing you ask the patient. That's basically what I'm saying. It can't be that the patient lies flat and you're like, Mama, lift up your legs. No. The first thing
Mm-mm.
should be you looking at your monitor and observing that your blood pressure has dropped or your heart rate has dropped.
Mm. Mm.
And also checking for pain or asking them, are you feeling pain, but not moving the legs? It's not the same nerves. So you can't be testing pain and motor at the same time because they're not the same nerves.
Mm. Can I ask you a
Yeah.
different question? Can raising the legs lead to complications? Can it push the drug where they're not supposed to go? Not really.
No, not at that time. I mean, if you're raising
Uh,
them for a long period of time, yes, maybe. Or if maybe you lift the legs. There was this old practice of after you do it, when I started as an intern, after you do the
mm,
spinal, you lift the legs. It's
mm,
it's not the right practice because of the the local anesthetic can move down, can move cranially basically.
mm.
Um, and you
That's what I
can
was asking. Mm,
cause high spinal actually when you do that.
mm, mm.
It's not being done anymore, the thing of raising the legs.
Legacy
It
practices.
yeah, it's actually not even, I don't know why we were doing it because I've never had to do it. So I'm trying to
Okay.
find the YouTube, sorry,
No
because I'm not.
stress, no stress. If we fail, I will share with the colleagues via email, everyone who has attended. Wilfred says, if both epidural and spinal work in terms of blockage, why do we often witness failed spinal anesthesia? Patient feels pain despite the injection. Sometimes it's psychological, sometimes they feel the pressure, not the pain, but sometimes it's true pain, I guess. Dr. Mpo, your experience?
Yes, so remember that patients are also anxious. So there's that anxiety part of it. You have told the patient that you will not feel mama, you won't feel anything. And that's partially not true. They might feel that, okay, they are doing something, but there might not be any pain. So when patients sometimes feel that something is being done to them, they panic, even if it's not pain. So,
Mm,
and then the other thing might be that your spinal, so when you put in the spinal and the spinal, maybe just go back with the slides so that I can show. When you put in the spinal and your spinal is not in properly, you can put it in and it's in the subarachnoid, but it's halfway in. And when you look at the needle of the spinal needle, there's an opening, and if your needle is halfway in, you think you are injecting into the subarachnoid space completely, but some of it is not getting there. So you don't
mm,
have a good block that happens because some of your drug is not getting where it's supposed to. So it might be that you are not in the right, you're not completely in the subarachnoid space and your drug is not completely going
mm,
where you want it to go. And so the dose that you're injecting, it's way lower. So the level of blockage is way lower than what you want.
mm.
So there are a lot of factors that
Subarachnoid.
affect, yes, there are a lot of factors that affect why the spinal doesn't work.
mm,
So maybe look at the technique that you're using and how quickly you get the patient lying flat. Because if you sit the patient, remember I said the gravity thing, that when your patient is sitting for a long time after spinal, you might end up making your spinal go a bit more sacrally and on the lumbar area. So you need to sit
mm,
them, because when you do a Caesar, you want your block to at least be above the umbilicus. That's what you want. But if you waste time to, when you put the spinal and you don't make the patient lie flat quickly, you might affect the distribution of your local anesthetic.
mm, mm. And then there was a slide there where you were saying the distribution is affected by so many things: the rate at which you inject, the
Mm-hmm.
weight, the light. You see, I was listening.
Yeah, I'm impressed.
You remember the slide, colleagues? I hope you remember the slide. What position would you tilt the OR table for a patient with high spinal? You mean now if you suspect high spinal or to prevent it? But anyway, let's assume it's a patient you suspect that they have a high spinal. Does tilting the table help?
So they do say maybe if you tilt the head up, you might be able to affect the local anesthetic going more cranially.
Mm,
Um, but remember that the blockage is already there. Like the drug
mm,
has already gone into the nerves. So
mm,
maybe you are decreasing the ongoing problem that is already there, lifting the head or lifting the
mm,
whole back a bit so that you can um, the spinal can go a bit more further down than it goes up. And
mm,
I mean, if you already have the patient having a high spinal, especially a total high spinal, your your management will be to tube the patient, yes, raise the head, and then you treat whatever symptoms that the patient has. You manage everything as it
mm,
happens. If the bradycardia is there, you give them something for that. If they need
mm,
vasopressors, you give them vasopressors.
And I mean, I've heard of maternal deaths, and they say it's high spinal. Is it the high spinal itself, or is it the failure to ventilate the patient? What's your, because the way I looked carefully at those two slides, it did seem like, okay, high spinal is an adverse event or an adverse thing which happens, but more than half the time we should be able to respond, and maybe people are focusing on the high spinal than maybe responding to how the patient is presenting, and maybe intubating them, and high care ICU, those kinds of things, because we do have maternal deaths from high spinals.
Yeah, we do have them. So yes, the delay, I think the delay is the most important one, that you don't pick it up. And
Okay.
maybe when it happens, the thing is, when certain things are not familiar with you or you don't see them often, you do get um, quite surprised when they happen, and sometimes we don't act as quickly as we do. But I always say that if anything, your patient stops breathing or you see it, just intubate. I mean, what's
Mm,
the worst that could happen if you intubate someone, you protect their airway, and you ventilate them? Give them oxygen. Don't delay giving oxygen, because patient becomes hypoxic and
mm.
they have brain damage from the hypoxia. So yeah,
Awesome.
I think
Awesome.
it's mostly not recognizing or also not acting quickly enough.
Yeah. I see two similar questions. Twarelo Sylvester. Sylvester says, approach to face spinal. How many times can you inject to get the desired effect? Now I thought you don't do that. Maybe you need to go GA, I
You mean
assume,
if
or
you do it, if you do
it's
it
like
and
you
then
you gave a spinal and it's
no,
classified as failed. I don't like this repeating. What's your and Because you can
So
see even
I'll
here, Sylvester says, can you comment on repeating spinal when the first one failed? I think if you have given the drugs, I wouldn't be repeating, but I don't know. I would be repeating
so
if I didn't get through it. But if the drugs are in, hey guys, I'm in HIV. Then please, this language, I don't know it, but I think I'm getting the science. Yeah,
so I'm
Dr.
like
Po.
you, because you don't know how much of that drug has already gone into space, and you might be overdosing
Yeah,
your
it's
patient.
gonna be difficult. Yeah.
So if you have a failed spinal, just do GA, convert to GA, because you
But
don't
you know
know how
why we are
much of
not
that.
converting? But you know the issues, right?
I
The
do know
real
the
the real
issues,
issue
but
why we want to repeat that spinal until it becomes spinal is because the health system has a challenge with the number of doctors who are confident in general anesthesia. Never mind clinical associates who are given the role when there's no one on call. So if it fails and now people they don't know what else to do, they just know let's try again, and maybe you have more problems now.
yeah, then that's
Hmm.
where things go south. So
Yeah, colleagues, let's take. Oh, you guys are typing, and if the promise you've been waiting for us today, my heart is like, I must try and answer. Okay, Mpo, let's see. Let's give short questions and see if we can take like the five. Let's say we can take five quick questions. Mpo is they say you're an academic. Hey, you see now that language, academician. Okay, but anyway, you're an academic of note because my tag is refusing. May she reach the highest levels of teaching many, many more colleagues in the future. Yeah, and I think your strength is how you simplify very complicated things. I looked at your slides. They can get complicated, but you have pitched them such that one can follow very nicely. So this is from Joy. Thanks, Joy, for that. I think Francis shares the same. Because right now, to be honest, personally, me, I did the rotation in anesthesia and I knew that it will never see me again. Now let's see. Let's say this is a fail, but okay, again it's fail. Like, is it the skills problem or can we really have a bad batch of heavy McCain? Okay, so this failed spinal. This blaming the drugs that maybe the drugs were not stored properly, they are not working. But I think it's multifactorial, right? And refer to the skills, refer to patient education and expectation, and then whether there's true pain or it's psychological, those kinds of things. But maybe you can comment on the drugs. Do you trust the quality of the drugs you are using?
so it can't be that the quality of the drug doesn't work when you are the only one performing, because you're not always the one who does the spinal. So it should be that your colleagues are also trying to perform spinals and they're also having failed
Uh,
spinals. We do have that
okay.
sometimes. We have times where we have failed spinals, and then we will have to write the batch of the
Yeah.
PPK and
Yeah.
and have to send it to, and then have to send all those local anesthetic to pharmacy, back to pharmacy. So it does happen, but it can't be that it's
Mm.
only you. It was a Lerato.
Mm.
It can't be
Let's
that
say,
it's
sorry.
Lisedi. It can't just be that it's only you who puts in the spinal, and
Yeah.
then the drug is the one
Then we blame the
to
drugs.
blame.
Hey, yeah. Okay. Anonymous. Yeah, this one I also wanted to. Wha- Do you have such a complication with an epidural where you say there's a high, not spinal, maybe high epidural? The drugs went to the brain,
I would say with an epidural, it would
but it can't
happen if
cross.
you're going, because remember you can do an epidural a bit higher. Like you can do it
Mm.
at there was a mid thoracic, and then this, yeah.
Yeah, let
If
me
you are
go to
very
that
high,
slide.
mm, so there is cervical epidural, which I've never seen, that you can do. So I would think that if you're if you're injecting the drug, the risk is always there, especially with bupivacaine. You can have the drug going where you don't want it to go.
Mm.
So it's possible. It's not common, but it's possible
Mm.
that the drug will end up going to the nerves that you don't want.
Mm. Hey, high spinal, is it common in obese patients? What's your experience?
I've 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 only seen it in pregnant patients. So
Yeah,
anyone,
for me, it's
I don't want to say patients, but I mean, it should be common in any patient that you're putting a spinal into. And remember, I said there's factors that affect why the spinal becomes high. Those factors that you have, it can't just be one thing that this patient is obese, so they're at risk of high spinal.
mm, mm,
No,
mm,
because the high spinal that I spoke about that we had in our hospital, it was not an obese patient. So
mm. Okay.
I wouldn't say weight is the thing. And I did say that weight doesn't really play a factor with you know, not well, that was with epidural. So
Epidural. Mm,
okay. I think let me
mm,
check that out for them because I'm
mm.
also curious to know if being obese can affect um can maybe make someone more predisposed to high spinal. Can I come back on that?
I suspect that maybe the actual spinal procedure may be difficult because maybe the distance to the spine and maybe your needle is short. But I don't know how that then I don't know. Let's leave it and then you'll advise us. Now, epidural and pulmonary embolism. I'm not sure if Anonymous says you can have an epidural creating an emboli or patients who are getting an epidural have a risk of clotting and therefore they may have emboli. I don't know. What's your understanding of this question?
So the slide that I presented was there's less risk of pulmonary embolism
Mm,
with an epidural. So I don't know exactly what they are asking me. Do they want me
mm.
to?
No,
I
just
don't
say
know
talk
exactly
about
what they're
it.
asking.
That is the actual sentence says talk about pulmonary emboli and epidural. So yeah. Right. So
Yeah.
few things that keep on cropping up. How often can we repeat spinal anesthesia? Don't repeat it. Can lying flat very quickly, immediately, potentially lead to high spinal? If it's flat, no. But if your patient is like this and the head is down here, I suspect that you may create more problems. That's why we don't elevate legs anymore. There's no science behind it.
Yes.
How many attempts do we need to declare a failed spinal? One attempt. Don't repeat it. Colleagues, why are you
um,
repeating spinals?
I don't
Because
know
you're not
how
supposed
many,
to.
but I mean,
Yeah.
remember when you're doing these procedures, you also have to, you're not just doing, you have to consider the patient, you have to consider the theater time, you have to consider your surgeon,
Mm.
and I can't be poking one person 10 times. I mean, we have to think it's a human being who feels pain.
They're
Um,
not talking about poking here. They're talking about injecting again and again and again. Don't inject again and again.
inject
Poking,
what?
we know.
Spinal
I'm telling
anesthesia.
you. I get all these questions.
No, no. Spinal anesthesia
If we
is
have 10
once.
questions, let me tell you, if we have 10
Epidural is a
questions tonight,
continuous thing.
if we have 10 questions tonight, six of these are about failed spinal and they need to repeat it. So obviously, if it's like doing a lumbar puncture, isn't it? You are trying to go through and you're not successful. That we understand. Maybe ask someone to come and try eventually or reposition your patient, whatever the issues are. But if you go in and put in the drug, there's no repeat. I think we sort of agree on that one. Valvasa, Valsava, Val, Valsalva
Valsalva
maneuver,
maneuver.
when you have given a spinal to distribute, is it something you practice? Is it advisable to
No,
help
it's
with the
not.
distribution?
No, it's not something I've done. I've never even heard you can do Valsalva maneuver to distribute the
Look at
spinal.
this. Dr. Nondanta says Dr. Mpo is at the apex of the leadership lead. Dr. Mazia. Today, you guys, I'm telling you, you are on fire. Okay, the last question for the night. This is it. Wilfred says there is a risk of a high spinal in pregnancy due to reduced space. But in a non-pregnant patient, the risk is low. Some of the
Mhm.
contributing factors is height, because short people will need lower doses as compared to tall people. Did they say BMI? On your factors there, I didn't see height. Was there
I
height?
did
I
mention
think
height, but it
height.
was
Okay,
not
yeah,
it
okay.
was not on epidural. It was not on spinal, it was on epidural.
That's on
But I can
epidural.
answer that with the spinal. So yes, with the
Okay.
spinal, we give them a higher concentration because,
Mm-hmm.
okay, so the person who asked the question did most of the work for me. In a pregnant patient, your subarachnoid space is pressed. So if I'm giving a drug into that area, it has a longer time to spend in that area and it becomes very dense. In a patient that is not pregnant, the area is not compressed, so it's big. So hence with pregnant women, we give a much lower dose because you know that when you put that drug in L3, L4, it's going to stay there and it's going to be quite dense around that area and it's going to block quite well. And that's why you get such a pronounced response with pregnant women. But in someone who is as tall as Dr. Leseo, and you give a spinal to him, his space is this big. It's not as small as that pregnant woman. You can't give him 2 mils. You can't give him 1.8 of bupivacaine. It's just gonna go up, go down, and it's not gonna do anything. Do you
So I
understand?
must get
The
a
district.
higher
So
dose.
there's more space of that drug to move around, and it doesn't stay
Yeah.
in one place for a long time. So it doesn't. Remember, the drug needs to get into the nerves. So if I had to give a non-pregnant patient 1.8 mils of bupivacaine, it's not gonna have a very good block. So the taller the patient is, we do give them a higher dose. I give males up to like 3 mils of bupivacaine. Yes, I know everyone is scared. 5% bupivacaine. Yeah, 0.5% of bupivacaine. Yes, I give them around 3 mils, some of them very tall. So when someone is short, you would have to give them less doses. Like if it's a very short pregnant woman, maybe less than 1.5, you would give them maybe 1.6. You have to take the dose a bit down because that drug doesn't have a lot of places to go to. Do you understand? Yes. So the
Awesome.
height does play a role, and the pregnant and the non-pregnant is because of the area that the drug has to cover.
Awesome. Awesome. Colleagues, give me a thumbs up to show that you are good. I really didn't want to stop this one without answering your question. I mean, you are still here. It was going to be a little bit unfair. So, you guys are still here. I am impressed. You guys are just going to be great clinicians. Remember when we're talking leadership, grow yourself today to be better tomorrow. But to grow today, commit intentionally 1 hour every day. If you do it the whole year, I can tell you by the end of the year, you'll be massive. Yeah. The
So
other
I
thing I
did
wanted,
send you the
yes,
video, eh? I sent you the
uh,
video on your phone, the
phone,
YouTube,
it means
because
WhatsApp. It means WhatsApp.
yes, because I can't find it with this. I can't multitask now.
Let me see what happens. Hey, this guy is fast. Okay, colleagues, one last moment. Let me show you this. It's actually very short. So let me see if I can show you the preparation. I need my Pirali Nagajugu, yeah, I'm better technology or there. That's when I feel at Dr. Mpo. That's when I feel. So don't feel sad. We are together there. Awesome, awesome, awesome. So I will share it on the WhatsApp groups, and then also in the micro lesson, we will embed this one and the other one, which was showing, I think, the insertion, yeah, the procedure, and then you can then review them. All right, Dr. Mpoyo, closing remarks, and thank you again for really trying. And you realize in life, every time you're about to give up, that's when the magic happens. I don't know why that is like that. So, colleagues, don't give up too easily. When it feels very painful, like this thing will never happen, that's when it's about to happen. Yes, Dr. Po?
I think what I wanna, the message I want is remember that um, you need to be prepared for the worst when you're in theater. When you have put a spinal on epidural, you're committed to anything, you should be ready to intubate the patient. You cannot put a spinal without knowing how to do AGA. I know that because I was also a com server at Shongwe Hospital somewhere, and we didn't have a working anesthetic machine at the time, and everyone was scared to touch that anesthetic machine. But we should all be comfortable to do a GA or get to a point where we're comfortable to do a GA, and also be ready to do a GA. Giving a patient ketamine when the spinal fails, it's not the way to go. So let's try and uplift ourselves, increase our skills, do better for our patients because they deserve better. And it's only us getting those skills, being informed, and come visit us at Ro Ferreira. Maybe you can come and then we teach you how to do a GA.
I'm not visiting. Well, I am visiting, but not for any procedure in anesthesia.
Okay.
But colleagues, maybe before we look at people laughing at me, before we close this one, we want to launch the diploma in anesthesia. Can you just type a yes there in the chat if it's something you'll be interested in? Remember, there's two things about it. Either you want to write the exam or you just want to be very good with anesthesia, even if you don't write the exam. Give us some ideas to say, yes, I'd be interested to learn more. At the minimum, is just to join the group, go through and it's not 3 months, this one.
Oh, wow.
Mpo is what?
Oh, wow.
Mpo's program, which she sent to me, it's like 6 months or something. Is it 6 months?
It's 6 months. Okay, no, now it's gonna be
It's
five
6 months. I'm
months.
like, yeah, okay.
But I mean,
If you
there's a
think of
lot.
exams, yeah, if you think exams, yeah, it's a longish program. But I think for me, even if I was not writing the exam, but I just wanted to, just I don't know, boost my confidence in all these drugs and whatever issues, anesthesia. Like I said, as soon as they signed me off, I was like, bye. Like obstetrics. I just wanted to be in internal medicine. Literally, that's what I wanted to do. All right, colleagues. So yeah, we are still trying to cook it. So you might get an announcement or something along those lines. Let's see what happens. At least boost your confidence. And if you want to write, let's see. But for me, it's just to improve our competency in that space. So we will let you know when we are ready in the next couple of weeks, maybe a week or two. I don't know. There's few things I'm waiting for from Dr. Traule there. So yeah, put her under pressure, call her, WhatsApp her, find her on Facebook and say, when are we starting? When are we starting? The last question, maybe to you, which literature did Dr. Mpo read for her DA? Is there a specific, if there was one book, or I don't know if it's a book or do you do on articles or books or what? How does it work?
Um,
What would be the one top two, top one read?
so I read a lot of the world anesthesia. What they call it? They call them weekly. I forgot what they call them, but they have this. If you join the World Anesthesia Organization, they have these weekly topics that they talk about. So that's what I read because I also wanted to be reading things that are not outdated. I wanted to read updated and also
Mm.
get used to reading things where they do evidence-based medicine or the studies that have been done, because that's the direction that medicine is moving into or has already moved into. I did read the Morgan and McHale, but not all topics.
Is that a textbook?
That's the prescribed book, which I
Yeah,
find
they
hard
tend
to
to be
read.
outdated.
Yeah, and then PMB has a very nice compilation of different PMB's book has a very nice compilation of articles for the DA, and they've put them according to like systems, which system or the order of how you should be reading them if you're doing respiratory. I read that. I used that. And when I was tired, I YouTube guys, and I felt guilty that I'm not reading the book. I YouTube and I listen to a talk, and the internet. We have resources and we don't realize them. You have YouTube, you have people who take time. One of the things I used to do was listen to a podcast, doctor from Australia. It's called ABC Anaesthesia. Every time I would drive to work, I would listen to that. And I used to drink, eat, sleep anesthesia for that 6 months. So that's what I used to do. I made sure that every day I did something, even if it's just me listening to. And when I was in theater, I would because sometimes you're reading something and then when you go to theater, you're doing something completely different. So if I've read that topic, then on that day I'll revise, like literally do everything book to book. If I'm doing a thyroid case, I will give anesthesia to that patient according to the book. And that helps as well, because if you are doing things according to the book, even if you have a mind block in the exam, you have done everything according to the book every day. You don't have far to go. You're just like, oh, okay, what did I do when I was in theater? So that's why it's so important that you practice your anesthetic skills the right way. You don't cut corners, because when you're writing the exam, you don't have to, I'm not a person who can, I don't know, I'm more of a practical person. I have to remember, okay, how did I do it? If I have to cram, I'm not gonna remember. So I'm more of a, I have to see, and then I'll remember it. Some people can cram, but yeah.
Awesome. 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 Yeah, so Koketa, I see you there. I'll talk to Dr. Mpo and we see if there's resources to share. But in the next couple of days to a week, do expect some announcement. Maybe I'll ask the team tomorrow to do a register for interest for anesthesia. Whilst me and Dr. Mpo, we get ourselves sorted. Night, colleagues. On that note, I think I've kept you long. I've never kept, our webinars until this time, but I'm just encouraged by you guys remaining here. Night, rest well. Enjoy your weekend with your beloved till we meet again
Bye.
next
Thank you
week.
for your
Thank
patience,
you.
guys.
Bye.
Bye.